Good morning to our viewers in the United States, and good afternoon to our viewers in Europe. I'm Steve Sokol, the president of the American Council on Germany. Thank you for joining us today. 2020 has been overshadowed by the novel coronavirus pandemic. National governments, societies, healthcare systems, and multinational corporations have raced to contain a constantly evolving public health crisis. Just last week, Fresenius Medical Care released its 2020 annual medical report. In it, Dr. Franklin W. Maddux, the Global Chief Medical Officer and member of the Management Board for Fresenius Medical Care, contributed to a special section on FMC's COVID-19 response. I'm delighted to welcome ACG Board Member Frank Maddux to talk with us today about how agility, ingenuity, and innovation have helped Fresenius Medical Care come to terms with the pandemic and share some lessons learned. Frank, thank you for taking the time to talk with us today.
Thank you, Stephen. I'm very glad to be here. Join you.
Over the last 30 years, Dr. Maddux has gained experience as a physician, expert nephrologist, technology entrepreneur, and healthcare executive. He joined Fresenius Medical Care in 2009 after the company acquired Health IT Services Group, a leading electronic health record software company, which he founded. Frank Maddux previously served as Chief Medical Officer and Senior Vice President for Specialty Care Services Group and is the former president of Virginia's Danville Urologic Clinic, where he was a practicing nephrologist for nearly 2 decades. His writings have appeared in leading medical journals around the world, and his pioneering healthcare information technology innovations are part of the permanent collection at the National Museum of American History at the Smithsonian Institution. Today, Frank Maddux will begin with a presentation and then take questions. So with that, it's over to you.
Great. Thanks so much for that introduction. And I look forward, I'm going to share my screen at this point, and I want to take the next few minutes and actually provide you all with a picture of how we at Fresenius Medical Care have in fact thought about addressing the pandemic, responding to the changes that we saw sometimes on a day-to-day basis and at other times on a more long-term basis, and use that as a way to frame the discussion on the impact to an essential healthcare company that this pandemic has had, one in which we have sort of both a footprint not only in the US and in Germany, but in fact throughout the world. So I thought I might actually start by giving you just a quick sense of what our global network looks like. We have just over 4,000 clinics dialyzing close to 350,000 patients with end-stage kidney disease, requiring dialysis therapy several times a week at a minimum, if in fact they're going to avoid some terrible consequences from the fact that they have lack of kidney organ function. So these are sort of the continents in which we divide up our 4 primary regions. But we're also a vertically integrated organization so that we produce dialyzers, supply equipment, and dialysis machinery to, in fact, serve the population of patients, both that we dialyze and also others that are dialyzed through these almost 40 plants and distribution centers throughout the world. So we had essential workers in not only the services area where we were on the front line with patients taking care of them, but we were also creating a supply chain and manufacturing requirement for critical workers in producing equipment that is substantially needed for the world's renal replacement therapy treatments. And this gives you a picture of sort of the scope of our direct work with patients, but also the indirect work with regard to making sure our machinery and our supply chain was robust during these times. These representations of both the dialyzers produced and the machines used recognized that our manufacturing requirements throughout the pandemic have been quite essential. And they were added to by the fact that the general population dealing with the pandemic had a very high rate in the 25 to 30% range of acute kidney injury for those people that required hospitalization with COVID-19 to receive acute renal replacement therapy. And those therapies we can talk about a little bit later were one of the things that were clearly required for our company to respond to during this time. This is the annual medical report that Stephen mentioned, and it is it's a group of 40 of our medical officers and other authors from within the company talking about things that we think are working, things we think are not working in our field and in the work that we're doing, and things that we think need to be considered for additional work. We added a special section on coronavirus because it's had such an impact on us this year. And you'll see some of the results of that in some of my comments that are coming up. This is available online, as we also have physical copies, but there is a full copy online at the Fresenius Medical Care websites if anyone is interested. This was what we saw right at the beginning. So year over year, we track symptom screening on all patients that we treat. And this happens to be a graph of a series of year-over-year graphs of a combination of two of those symptoms that we monitor, that is cough and slightly elevated temperature. And as you will see, the blue and red lines represent 2018 and 2019, with the beginning of 2018 being part of the influenza season from that year. But what we saw beginning about week 11 was this remarkable increase in this combination of symptoms that began to show evidence of a peak. This particular graph is a graph from North America, and it referenced the timing that we saw the surges begin to occur predominantly on the East Coast, New York, Boston, Philadelphia, New Jersey, and these areas, and then some secondary peaks that have occurred later in the year as we begin to see that spread occur into Texas and Chicago and Louisiana and other areas that subsequently have had distinct surges. So we had this opportunity to look at symptoms as we went through this. One of the ways our epidemiology group tracks this, and I sort of took a snapshot through June of this from the beginning of the year, is we track not only what our daily case rates look like and what they begin to look like cumulatively, and we track that not only by continent and region, but we track it down to the country level, in the country to the region within the country. So in the US, it's at the state level. In Europe, it's, for many of the countries, it's at the region level within the country. So we look at daily case rates and what the pattern of that looks like. We look at cumulative cases, and these cumulative cases have grown to date to right about 19,000 total cases of exposure in our patients since the beginning of this pandemic. We know that the general population across the world has seen more than 33 million cases and about 1 million deaths. In the US, just over 7 million cases and over 200,000 deaths. In Germany, remarkably fewer at about 287,000 cases and just under 10,000 deaths. Week over week, we not only look at these case rates, but we look at essentially the first and second derivatives of the case rates. So we look at the rate of change in the case rates week over week, and that's in the top graph here. But then we actually look at where we see accelerations and decelerations of that case rate. And the accelerations and decelerations give us this sense of what's happening with what's called the reproduction number of the virus, where we begin to see is the virus getting below to a point where there is essentially a declining number of cases and a declining spread of the virus. So this is tracked at this grand level all the way down to this very granular level on a week-by-week basis. As we looked at our planning imperatives, there were essentially 9 of these distinct areas where pandemic planning was put into place. And we've had a long history of planning for all kinds of natural disasters. I don't think we thought of a disaster like this one when this year began. We were certainly not anticipating this. But we do have, every year, we have fires and hurricanes and tornadoes and occasionally tsunamis, and we have earthquakes and hurricanes and such things. So, so there is a very active emergency disaster planning process, and these were put in place with this infectious disease pandemic to add several elements to that, certainly around testing, tracing, and isolating, and especially around looking at our capacity to manage the not only chronic patients we care for, but the acute patients as well that were new to us. Organizationally, this is divided down, and when we look at the various pillars of the response, it runs through the way our organization is structured, but each region, which is basically North America, Latin America, EMEA, that includes both Europe, Middle East, and Africa, and our Asia Pacific region, essentially had an operational crisis team that at points during this year, they were meeting literally every single day on various issues, both medical and clinical issues, but also these other issues of communications, operations, public affairs, and so forth, guided by direction from our various boards and key coordination areas of the organization. Many of these things led to a cadence that continues to go on today, and this cadence includes weekly crisis management calls today, the sharing of clinical experiences, and we had this ability to see what was working in Asia before we had to deploy resources and respond in Europe or in the United States or in Latin America. And this is an enormous advantage that gave us the ability to do this. We developed communication activities in which there was a global communications site that allowed us to share COVID-19 information and recognize what was happening both regionally, but what was needed globally, and whether this was around our clinical understanding, because frankly, none of us knew a lot about this virus as the year began in January. And we were on a very, very steep learning curve clinically and scientifically. But likewise, we had to respond from a procurement standpoint substantially. And so there were these various work streams around clinical management and our supply chain and our continuity of business and our communications capabilities that were really put to the test and actually required a fair amount of creativity as we got into it. And I think we, in general, were scrambling many weeks out of the beginning of the year and got into a cadence probably by the beginning of May that has continued at this point with a very active dialogue across our regions. There were over 20 guidelines that were produced in our network that included guidelines around patient management and how we managed our workforce, how we managed working from home as an organization, but especially around the clinical elements of testing and hygiene and infection control guidance and medical management. But these were things that were extraordinarily important for us to be able to see how our patients were doing on a regular basis. And this is a snapshot from our system outside of North America that covers our EMEA, Latin America, and Asia Pacific, where in 42 countries we have a single system that's collecting about 11 million data points on patients per day. In North America, we have a system that's actually collecting about 30 million data points on a much larger population of patients. And this adds up to a massive amount of clinical data that gives us a chance to do real-time monitoring. And I'll show you later some of the research that we have done around coronavirus has been directly related to our ability to capture clinical information on our patient population and use our advanced analytics teams to try to figure out what some of the insights were while this was evolving and continues to evolve. We had to put out a variety of global medical advisories, and this was one. In the time frame of late April to mid-May, we found both countries and regions and local governments and health systems were beginning to look at whether they would limit care to certain populations of people with certain chronic illnesses. And this became a very substantive ethical issue for us, in that we felt that we needed to put an advisory out that our patient population was not receiving much of any of their care that was elective without the care that they require on a regular basis, either at a minimum 3 times a week and sometimes daily. These patients can't survive without being able to get access to appropriate surgery or procedures that need to be done that maintain their life without adequate kidney function. So we put out a very, very overt statement around what our thoughts were related to care apportioning and some of the things that we were beginning to see that were potentially going to create, I think, substantial dilemmas between prescribing physicians and their patients that had substantial needs and access to resources. So we advocated heavily for that, both in our advisory, but also in the public space. I did this review in Becker's Hospital Review, trying to stem the tide, and we were able to do that probably in 7 or 8 distinct cases that came up both in Europe and in North America regarding this. These 5 areas are perspectives that I want to very quickly, in the last few minutes of my comments, kind of walk through sort of what were some of the activities from patient perspectives, healthcare provider perspectives, for our employees within the industry and with some of the various governmental bodies that we work with, and then some of the research that we've done that has contributed to this very open access research consortium that we see around the world right now, people sharing what they've learned about the pandemic and the virus. Our patient journey was really related to recognizing that this population of patients are highly vulnerable. They are going to struggle if they get the virus, so we really needed to do everything we could to protect them from getting that virus. And that started with very aggressive screening and very aggressive masking. So in early to mid-February, we actually created a series of rules that we would mask both patients, staff, and anybody that had any interaction from their home into the dialysis facility and back to their home again. And this was originally a relatively unpopular decision because our personal protective equipment requirements went up drastically during that time. And so there were some that said, you're doing too much right now to try to do this. And yet later it was quite clear that with the population of patients that we have, showing that if you're a dialysis patient and you get coronavirus, about 50% of those people will be hospitalized. And after about 40 days, the mortality of those people hospitalized is really quite high. It's about 15% to 16, 17%, right in that range. And that's just extraordinarily higher than it would normally be, showing that this is a remarkably vulnerable population. So protecting patients was a big piece of this. The second piece was testing, and we developed testing strategies by continent, by country, that tried to dovetail in what was available in that country, as well as for any of our patients who were under investigation for the virus. We created individual calls to try to keep up with them and help them in their decisions, while at the same time we began working on transportation issues and access to care issues, and secondarily creating isolation clinics, which I'll talk about in a moment. The provider journey for physicians and clinical staff was really related to creating hyper-frequent communications platforms so people would learn. We have about 120 to 130,000 employees in our organization, and just trying to keep everybody informed on what was going on, especially those frontline workers, was a substantial challenge for the organization, and one that required lots of open forums, dialogues, replays of things, and access to utilizing technology to do that. One of the biggest things that occurred, especially in Europe as well as in the United States, was the ability to stand up telehealth solutions. And the example in the United States was the development of our telehealth solution that we got stood up in less than a week's period of time, distributed tablets to every clinic that we had in North America, and in the first 4 weeks had done over 450,000 face-to-face visits or virtual face-to-face visits between providers and patients, which allowed patients to at least make sure that they were seen and heard and listened to about what their symptoms were and how they were doing by their healthcare providers. The second thing we had to do was set up, and this was done in both North America and in Europe predominantly, were a series of isolation clinics and isolation shifts for dialysis, where patients that were known to be COVID positive could be cohorted together while they were infectious and go through a period of their continued treatment, but in a treatment or a clinic that was isolated to people that were exposed to coronavirus. And given in the United States, we have about 2,400 clinics. This represented a fairly substantial number of those clinics. Close to 20% of the clinics across the United States were set up as isolation clinics. And then finally, some of those clinics were dialyzing a lot of COVID positive patients. Now, in other countries, many of those patients would go into a government healthcare facility for isolation. And then the normal patient that was non-COVID positive would come out of that government facility into one of our facilities. So there was a bit of a swap that was occurring in patient populations in Asia Pacific and many of the European countries. But these isolation clinics in North America played a substantial role in what we've done. Our employee connection, this is a snapshot of a number of things that we did, but one of the key things was to recognize that as we saw surges occurring, we needed to find patient care staff that would volunteer to go into hot zones. And we had almost 500 people raise their hand and say they were willing to travel into an area that was surging and take care of patients during that time. We had a number of these people that would volunteer multiple times, and they would go on these sort of 60-day junkets into hot zones and supported, almost 200 locations that we have in these areas. We've been testing our staff fairly, especially our clinical staff in the front line and in the manufacturing plants, both from the standpoint of symptoms as well as testing. We've done well over 50,000 tests at this point of that, and we've communicated substantially through our both an app that we have for employees and our medical office newsroom became the central repository of the shared cross-regional information that we have put together on this as outreach to try to help everybody get educated, but also informed on what some of the best practices were for working at home, what some of the opportunities were to get tested if needed, or to manage groups of people when your work team isn't together. And so these were substantial. Within the industry, there's a lot more than what I can describe just on this page, but I would say we had emergency use authorizations in Europe, in China, in the United States for products predominantly around acute kidney injury care. This was both fluids and machinery that was both for continuous renal replacement therapy sessions for the acute kidney injury, but also we got emergency use approval for a device that essentially does extracorporeal membrane oxygenation and artificial lung support that we provide. That was equipment that was marked and licensed and on the market in Europe, got approved in the United States, as well as got approved in a number of the Asian countries, as well as in China. And so this combination of being able to ramp up certain production lines so that they would produce more of the product that was needed allowed us to try to get through some fairly difficult weeks where the surges in certain areas were not available, but in other areas it allowed us to build up some supply stores that would make it available as surges were beginning to occur. And we've gotten to a point now where we've got much better control over both the supply of acute kidney injury supplies and fluids and equipment needs, and where we begin to see hotspots. In North America, we were able to set up what we called a National Renal Replacement Equipment Reserve. And this reserve was taking areas of the country that were not hotspots and taking 10 to 15% of the supply of equipment that was not being utilized and redeploying that into areas that was where it was needed. And setting up that national reserve was one of the things that we uniquely did around acute renal replacement therapy. And then finally, on our medical office and science side, these are 5 of a number of studies that we did internally to try to understand and publish what we were learning about the virus. And so the first was interesting is we have the ability with the equipment we have to hyper frequently measure oxygen saturation on patients. This is the amount of oxygen that's circulating in their blood. And of course, with a respiratory illness like COVID-19, you get to the point where your body does not have enough oxygen circulating. So we were able to show that 3 to 4 days prior to development of symptoms, our patients actually began to experience higher frequencies of dropped oxygen saturations. And so we've got an entire list of analytical elements and quantitative elements that we measure on patients routinely. We can begin to see what was happening in a subtle way as they were getting sick with the disease and then symptomatically. And so we published some papers around that. We looked at this concept of reproduction number, which is this sense of understanding that if the number is above 1, you have an accelerating infection rate that goes through epidemic to pandemic. If you're under 1, you actually are decelerating and the epidemic is under control and can't really be spread. So we looked at how the reproduction numbers were occurring in our dialysis population within Fresenius Kidney Care, our services arm. The pool testing was something that got quite a bit of play because right after our pool testing report and math analysis that was done was reported in the Journal of the American Medical Association, Open Network Journal, there was quite a bit of discussion around how these tests could be done in a more efficient way and what was the requirement of the pandemic to show that pool testing, where you pooled specimens from multiple people instead of testing each individual one, was a better way to consider testing a population when your testing materials were in limited supply. And then finally, we showed that our population of dialysis patients is quite vulnerable, and that not only were the people that were recognized with symptoms in the disease important, but also that there was a whole group of asymptomatic patients that we see much more frequently now than we saw at the early days of the disease. And then finally, the last thing we've reported has been on an analysis we did where we wanted to know whether our disinfection procedures, where a dialysis chair, which occurs in a dialysis unit in a somewhat communal environment, whether the disinfection procedures were in fact effective in avoiding spread of the virus. And so we were able to show in sort of 3 settings, both a longer term setting where we looked at lots of treatments in a window of 3 days versus 1 day versus the same day, that in fact disinfection and surface disinfection and masking and personal protective equipment, being super aggressive about this, we were able to show that both patients that got infected were getting infected at the rates that were typical of their communities they lived in by their geographic codes. And secondarily, that the patients that would follow them in treatment in that particular location in the clinic likewise didn't have any increased risk of being infected, both in the short term or the longer term. And these were really quite important findings for us. So I think, Stephen, I will stop there and stop sharing and see if we can't just talk about some questions.
That was great. Thank you very much for that presentation. I certainly learned a lot, and I think our viewers did as well. We've already started to get some viewer questions, including one which is, can you share with us the turnaround time in delivering the test results? Was it near real time, one day, or did it take longer?
I will tell you that's been a huge challenge, and it was very different in different parts of the world. The testing turnaround times in Asia Pacific, as we got started, where we have lots of clinics in China, Taiwan, South Korea, Singapore, Hong Kong, Australia. Australia was a bit later, but the others were really pretty quick. They were getting turnaround times generally within 36 to 48 hours throughout pretty much the whole time, and sometimes shorter than that. In Europe, we had difficulty gaining access to tests in the early days. In Italy, in the Lombardy region, where we have both manufacturing plants and a lot of clinical services there, was hit extremely hard. And I think in Europe, testing went through a variety of cycles. It took us some number of weeks to get an adequate supply of tests, as did the same thing occur, but a few weeks later in the United States, where we have continued to have some difficulty in getting access to tests. We went through a number of different labs and testing protocols. We are currently doing genetic testing, where we now have a 24-hour turnaround time, which allows us to get a specimen to the lab and back. But at one point in time, it was close to 6 or 7 days, and that was almost useless from the standpoint of tracing and isolating patients. So we isolated people who were just under investigation. We isolated at one point close to 10,000 patients that just had some degree of symptoms, loss of taste and smell, a GI symptoms, a respiratory symptom, or a low-grade fever. We went ahead and isolated many of those patients. So we had these multiple isolation cohorts, known positives, what we called PUIs, persons under investigation, and then people that we know were negative. So it was pretty complicated, and testing continues to be complicated at this point.
I'd like to remind our viewers that if you have a question for Dr. Maddux, you can pose it using the chat function or by sending me an email at sokol@acgusa.org. Frank Maddux, I'd like to maybe drill down on a couple things that you brought up in your presentation, and one of the things that you were actually just talking about. Obviously, Fresenius Medical Care has both clinics and manufacturing facilities all over the world, and you were talking a little bit just now about the sort of nuanced and differentiated response in different countries, on different continents, and even in different regions. Given that COVID-19 began in Asia, spread to Europe, and then to the United States, were you able to learn certain lessons based on what was happening in Asia, then in Europe, then in the United States, that you were able to apply as the virus spread, both in terms of internal FMC operations, but also in terms of what are some of the broader lessons that you learned in that process?
Yeah, so I think the answer to your question at its base level is absolutely. We had the chance to observe what was happening early and recognize this was going to be a serious issue for our world fairly early. That allowed, that in combination with our Asia, a number of the countries in Asia had previous experiences with SARS, and they had very aggressive pandemic planning in place. We were able to look at that and then begin to respond on how would that translate in some of the other continents. So I would say the parts that probably influenced us the most were our recognition that when we began to see in Taiwan who extremely rapidly responded to what was happening in Wuhan, China, and put disciplines in place very, very early. We learned from that that we needed to respond as early as we could, and that influenced tremendously our decisions about personal protective equipment and isolation. And so our decisions to very aggressively procure masks and gloves and gowns beyond what we would normally use and create these relatively harsher levels of that in the early stages of the pandemic occurred quite quickly. We actually began that process, for example, in the United States in the third week of February, when we really hadn't begun to see much in the way of cases. And in Europe, we were seeing that we were going to need to test very aggressively, and there was a lot of work in not only testing, but then making sure that patients were sent to the appropriate government facilities that were taking COVID patients at that time. And then finally, our supply chain was one of the things that we needed to address very, very aggressively, and our global procurement group, our global procurement group allowed us to secure supplies well in advance of the rush to supplies. And although we've seen, as everybody else, a rather grotesque degree of inflation of the cost of those supplies, we've been able to maintain our fairly aggressive posture on trying to protect with PPE and both in our manufacturing sites as well as our clinic sites.
And I want to stick with the global perspective for just a moment longer. You and I had a chance to speak a couple of months ago together with John Emerson, the chairman of ACG. And one of the things that we talked about that remained with me vividly was that there appear to be different strains of the virus in different parts of the world. How has FMC dealt with that internally for the company, but also as a healthcare provider with this global footprint?
Yeah, so we began doing a very steep scientific learning curve on the virus, and we're quite interested in what we were seeing from a genetic standpoint of sort of viral mutations that were occurring. And frankly, by the time the virus came to Italy, it was very clear that much of the virus that had been circulating in Asia had begun to change slightly when Europe began to see it. And then later, when the US became involved, we began to see that the US transmission, although some of the first cases were in the Seattle, Washington area, and were thought to have come from Asia, and they may have, much of the large surge that occurred in New York and the East Coast was likely from Europe. And we could look at that from looking at genetic profiling of this RNA virus. And likewise, we see now that the spreading of the virus and the virus's ability, there's this, what's called the G614 mutation, that is substantially the prevalent virus that's circulating right now. But the virus has quite a bit of propensity to change its nature slightly, and we've watched that quite carefully.
So we have a viewer question that I'd like to read to you. Have geopolitical tensions, particularly between the United States and China regarding the virus itself, materially affected or hurt the global medical response? Do you already see any disruptions in medical supply chains due to protectionism? China has been supplying a large share of the world's PPE. Can anything disrupt that trend?
Yeah, I would say that I think there have been political tensions that have been affected on the cross-continental as well as the within continents that have occurred that have created tensions around supply chain access. In general, we are still getting our supplies predominantly from manufacturers in China. but we found that there were many new potential supply opportunities that occurred that were either fraudulent or didn't actually pan out. So we had to go to a relatively aggressive verification process, and we had to use all of our existing resources to try to make sure that we had enough either space on container ships or access to air cargo that would provide PPE. Within continents, we found countries became somewhat prescriptive on what was allowed across their own borders within the continent, and that became another challenge for us. So in both the United States, we had states that were protecting supplies. In Europe, we saw countries protecting supplies and borders, and we had to use our advocacy arms quite strongly to recognize that for us, because we're a multinational, globally spread organization, we are utilizing those borders actively at all times to get our equipment and our supplies where they need to be, as opposed to having independent distribution in every single country. So it's been a continuous, fairly large issue for us to deal with, and it's much better now. I would say in the month of May, it was quite difficult, and there was a fair amount of tension. I must say the geopolitical tensions that exist in our world today have not helped with any of this. I think we've overcome a lot of that to some degree, but it would be something that I think would be a good bit smoother if those political tensions were not kind of where they were today.
We've had a couple of questions about what the next few months might bring, and so as we head into flu season, can you talk a little bit about plans that you have to deal with COVID-19 and influenza simultaneously?
Yes. So in our northern hemisphere, countries and locations, we've recognized that this combination of coronavirus and influenza is going to make it very, very difficult to ferret out what's actually wrong with somebody when they come in with symptoms, whether it's somebody coming to work or whether it's a patient coming for treatment. And so we have actively tried to begin to prepare ourselves for a wave of illness with a lot of unknown infections. And so we've been looking at what are the opportunities to create testing panels that would allow us to look at both COVID-19, influenza, and RSV, which is another virus that typically circulates during this time. It's difficult. Some of these tests are expensive and not always easily available, but our thought is that we're going to continue to have to be somewhat hyper vigilant around this area and at least be prepared to have a second surge. From our business standpoint, we've been working very, very hard to try to recognize that because of the risk of a second wave, we've been very cautious about the way we have opened up some of our corporate offices and some of our locations where we have a lot of aggregated individuals. And our manufacturing plants have taken some long-term sort of isolation and distancing kind of measures in place for people to try to avoid what we think is going to be a relatively difficult fall and winter of 2020 and 2021.
Particularly since you raised the issue of a second wave, which I know is a concern for all of us. Where do you anticipate seeing that second wave? Is that something that is sort of universal and that we should expect everywhere? Or are there certain isolated regions where you would say we need to watch out more closely and be even more careful?
So the way I look at this is, how does the virus respond to the non-pharmacologic interventions? And how controlled are the environments where people live and work and exist in being able to create these non-pharmacologic interventions that help stall the virus? So whether it's masking or it's social distancing or it's isolation in some form, different cultures obviously have different degrees of either comfort or demands from their local communities on how that happens. And so our view is that I do think we're going to see some second wave hotspots that occur. And to me, it very much follows the pattern of where we've tried to either open up too quickly or we've tried to respond in a way where people just get fatigued from some of the non-pharmacologic interventions that are occurring. We don't anywhere today have enough exposure or immunity to really have a serious discussion that you've heard around herd immunity. And vaccination is going to come with a lot of challenges. I think not only do we need to figure out whether we have vaccines that will be effective in developing neutralizing antibodies that have long-term suppression, but we also have a couple of vaccines out there that are really a novel type of vaccine that we've not seen. So there will be vaccine hesitancy in a number of people and cultures and so forth that will make it somewhat difficult to get broad vaccination done quickly in a way that will assure us that we sort of have population-based immunity. So I think, to me, it's going to be a much longer pathway to getting back to what might be considered normal for us in many cases, and I do think there'll be hotspots.
I'm happy that you brought up the issue of vaccines, because that was something I wanted to ask you about, and I know it's something that's on the minds of many of our viewers. And I wanted to get more thoughts from you about where you think we are regarding the development, but also the production and then ultimately widespread availability of a vaccine. How long do you think that might take?
Yeah. So there are a lot of competing views on this, and I'll simply say the vaccine development process has been faster than anything I've ever seen. And what you're seeing is development of the vaccine and essentially at-risk production of these vaccines, so that if and when they get to the point where their phase 3 trials show adequate efficacy and safety, that once approved, there will be a body of vaccines available in reasonably large supply. All that is good and is going to help, but I think the degree to which the speed of these vaccine trials are going on is quite unprecedented. And even to fully understand the safety issues and other things, I think it could easily be until late this year or next year before we get some true degree of comfort that these vaccines are both working effective. And I think there is a base level of process that has to be done in a very disciplined way to get a vaccine that is both going to be fully effective, but also one that is recognized as fundamentally safe. I do think the manufacturers of the vaccines are being as diligent as they can be while they are essentially producing at-risk vaccine that they don't yet know whether it will make its way through the research gauntlet.
So obviously we're still learning about this virus, and we've gotten a couple of different questions that touch on symptoms, but also on testing. And I'd like to maybe try to combine them a little bit. Are we learning more about the kinds of symptoms that people are presenting when they have COVID-19, like dropped oxygen levels? And is this something that healthcare providers are watching out for? And related to that, a great deal of emphasis has been placed on temperature testing up to now, but should we be putting more stock into testing blood oxygenation? Is this something that we should all be doing on a daily basis, because this seems to be a symptom that is showing up more and more often?
So the virus is interesting. So the virus, as it gets into your oral airways and nasal passages, takes a little bit of time to get down into the lungs. But once it does get into the lungs and it binds and binds into these cells and gets inside the cell where it likes to replicate, it strikes me that it can actually present with quite a plethora of symptoms. They are sometimes respiratory symptoms, and that clearly was the early obvious representing symptoms. But we've also seen some very subtle symptoms from people that have gastrointestinal problems, both upper and lower GI problems, people that have lost a sense of taste and smell. So the virus actually seems to have a capacity to have impact somewhat differently on different vulnerabilities that people might have. And with its relatively long incubation time prior to symptoms, that's one of the things that makes it sort of a more dangerous virus, in that there's a period of time before symptoms occur. So the oxygen saturation is an interesting thing that we've observed in our patients who are highly vulnerable and at risk for this already. Whether in the general population, oxygen saturation testing would show that same subtle difference is not clear. That's not been looked at today that I know of. And yet I think most physicians in urgent care centers and emergency departments and clinics would say that right now, if a person comes in with an unusual symptom complex, COVID-19 is at least something to think about, because it has presented in so many different ways at this point, and in some cases it's presented completely asymptomatically, that most everybody would have a very low threshold to test. I do think over time the testing is going to become easier and quicker, and if you look at a very nice article that was in the Atlantic Monthly by Michael Mina, and this approach towards trying to get to a very low-cost saliva-based test that we could all learn to test on a very frequent basis, every day, every other day, or something like that. These various technologies, as they develop, I think those will be ways to try to figure out how to identify somebody much quicker, and will be more useful than this relatively aggressive nasopharyngeal swab that people are having to go through.
So I'd like to switch gears a little bit, because I feel like I'd be remiss in not taking advantage of this opportunity if I didn't ask you about data and privacy issues set against the backdrop of this pandemic. As some of our viewers might know, earlier in your career, you developed one of the first laboratory electronic data interchange programs for the US dialysis industry, and later created one of the first web-based electronic health record solutions. And so, you know, you're an old hand when it comes to collecting data when it comes to healthcare. And now, with the widespread use of contact tracing applications to try to contain COVID-19, there seems to be a heightened awareness and caution regarding data privacy, certainly in Europe, but also here in the US. Can you talk a little bit about these concerns and whether or not you share them?
Yeah, so healthcare privacy issues are an enormous topic right now, not only because of the pandemic, but just in our time with the HIPAA privacy rules in the US, with the GDPR rules in Europe, and with the advancing of personalized sort of precision medicine with use of genetic information to try to characterize disease and mechanisms of injury. This is an enormous issue that we all have to try to address and begin to think through what is the appropriate level of privacy that we should expect. In a public health condition like a pandemic, it becomes very, very instructive of the political worlds that we live in individually that really begin to drive what that discussion is, country by country, continent by continent. And I would say we are in the relatively early stages and a relatively immature point of those discussions as a group of societies. Generally, I think contact tracing for public health conditions is quite a challenge today, and certainly we know that contact tracing in many of the Asian countries is a bit of a demand item. It is just part of the policy of the country. You're going to live with this. And we've seen the impact of that. It has slowed the pandemic there. We're here in the United States where we essentially cannot contact trace effectively today. We see the worst results from a pandemic public health standpoint. So the right balance is somewhere in there. You've got, Germany's done a remarkably good disciplined job in trying to uphold some of the principles and avoid some of the hotspots, but then when needed, have fairly strict isolation rules. And so I think it's there are cultural overlays, there are social overlays, and there are certainly political overlays that are going to make this a pretty complicated discussion. I do not think there's one answer that's going to be right for everywhere. But the virus doesn't care about our politics. The virus wants to do only one thing, and that is reproduce itself. And its reproduction will look towards that environment that gives it the best chance to continue circulating and surviving. And I think that we're seeing the impact of that today.
Well, as you just said, the virus does not care about politics. It also doesn't care about nationalities or national boundaries and borders. And in closing, I wanted to talk to you a little bit about where you might see some opportunities for collaboration. Of course, Fresenius is a company based in Germany. It has a large global presence, but it particularly has a large presence here in the US. And as an organization committed to strengthening the transatlantic and specifically the German-American partnership, do you see ways for greater bilateral or multilateral cooperation to deal with the pandemic, despite the levels of uncertainty and to some degrees the lack of trust that we're seeing play out right now?
Yeah, so I certainly think in my world of healthcare, I see substantial opportunities for us to continue to share very openly science around what we know about the virus and the pandemic and the treatments and the vaccines and all of the work that's being done to try to understand this pandemic. I think if we were able to have honest conversations between the countries around what's working and what's not working, that were quite transparent, we would begin to identify what are some of the social and cultural things that should be supported from our both governmental, political, and community environment. And then finally, I would simply say, I think we have all learned that we can do things in a substantially virtual environment, and it offers us the chance to try to broaden the viewpoint of how we get medical equipment and medical supplies that are working well under one regulated body available to another regulated body. These emergency use authorizations have been quite telling about what is truly important, and the fact that when the need is really there is opportunity to share some of the work that's been done. If we could share our research work across some of these various notified bodies, we would be able to move along the advancement of our medical scientific innovations a little bit quicker. And I think whether it's between Germany and the US, or whether it's between China and Germany, or whether it's between any of the major continental bodies that are looking at regulating medical devices, medicines themselves, I think there is huge opportunity to learn from the pandemic that we can actually work together a little bit better.
Well, Frank Maddux, I want to thank you for this very nuanced and transparent conversation about confronting the common challenge of the COVID-19 pandemic. It's been incredibly informative for me, and I'm sure for our viewers as well. And I just want to thank you for taking the time to share your thoughts with us today.
Well, great. Thank you very much. And I appreciate the chance to have conversation with everyone about this.